Okay. All right, very good. Okay, welcome everyone. It is about 3:07 on Wednesday, the 20th of January. This is a special legislative commission reviewing the rules and regulations of the Rhode Island Medical Board of Licensure and Discipline. It's our January meeting. Today our agenda includes two main items. The first is a presentation of the materials that we received per our last meeting, where we had some questions that we had put out there and then some requests for documents, etc. Jeffrey Robert is going to be giving that presentation. Of course, there will be an opportunity for questions. And after that, we're going to have Steve DeToy from the Rhode Island Medical Society. Steve's a fixture in the building and knows us all well and knows the process well, so I am certain that his portion of the hearing is going to go smashingly. So, so with that, I would like to turn it over to Jeffrey Robert, please.
Good evening, Chairman, members of the Commission. Thank you. So today we're just going to go through some of the information provided by the department. It does not follow the actual questions that you received. It more flows from a different perspective. So starting off, appropriations supporting the BMLD, just inquired the department how much what do you receive, and that was a little challenging to get a response from because the department's functions are broken down into different avenues. So you may have the chairman who only works about 50% of the time on BMLD functions. You can see from the slide that his other roles are outside of BMLD functions. So it's just challenging for the department to provide that information. This is a slide compiled with other data that you have received. It's been compiled from other requests. It's the last slide that is highlighted here that just shows the amount of fees collected. If you do recall, there is a statute that allows the BMLD to collect fees from doctors. These are not fines by statute. They are just administrative fees that can be collected for administrative work if a doctor is found unprofessional conduct. And you can see from here how the numbers flow. Moving on to the question for team review procedures, if you do recall again, the team review is the initial triage team. It is comprised of the BMLD chief, board attorney, and investigator. Those three individuals come together at the beginning of the process with the complaint cover sheet and determine whether or not a complaint is going to move forward. Move forward in the process means reach the investigative committee. As it was testified last time, complaints meet a very base criteria, and they can be opened for any particular reason as illustrated here, with the fourth being that any one member of the three wishes that a complaint be opened, it is done so. Again, you have seen much of this data. It is again compiled with another slide highlighted. These are consent orders ratified. Consent orders ratified is very similar to the data that we asked for consent orders decreed. So a decree would be given to a specific doctor, and then it would be ratified upon their next step. The data was so very similar that I just showed this for illustration purposes. Upon further analysis with the department, we found that in 2007, there was a different type of criteria, and that if a doctor were sanctioned in another state, there would be a consent order ratified in the state of Rhode Island. So it has since changed from then, but you can see the slight uptick was, I believe they said 19 specific cases were related outside the state of Rhode Island. Complaint cases and how are they determined? Unfortunately, right now the BMLD does not track the relationship of the complainant. You can see this is a clip of a cover sheet, and I do believe that you have the entire cover sheet in your packet, in the packet that you have today. There is a line that illustrates source, the source of the complaint. Yet prior to 2015, it was never tracked, unfortunately. That being said, since 2015, it has been tracked. And one of the questions that this commission posed was the number of staff complaints input by the BMLD, its staff, or affiliate departments. The BMLD's presentation materials illustrated that 66 complaints were logged in the year 2015 by staff or its affiliates, which represents around 16% of the population, to give a roughly 400 and change number of complaints. The Investigative Committee, as you may recall, from the triage team, the team review, it then moves to the Investigative Committee. That is a board of 3 or 4, depending on, I believe, which board. For the materials that we'll be looking at today, we're just going to assume a board of 4 members. To have a quorum, which was a question that came up last hearing, 3 of the 4 members must be present in the room to have a hearing, to make a determination. This is the committee that determines whether or not a doctor is considered NUPC, which is non-unprofessional conduct, and UPC, unprofessional conduct. So this question states that 3 of the 4 members must be present to go to the next stage. If not, those materials, that entire hearing will be pushed to a later date. Physicians and investigative committees. Now, this came up last hearing. Past BMLD commission hearings have been described as an informal meeting without record. No stenographic record, yet the discussion may lead to information that is included in the finding of fact. And that was the question was posed by this commission to the department. At what time is the doctor notified that this hearing may be used, either in the course of the investigation or at some point? And the department wrote, there is no pretense that information is off the record. So if you'll just indulge me for one moment, I want to minimize this and play a quick clip from last hearing.
They invite some of the physicians in, and then if a physician requests to come in, usually that is granted.
And is that all recorded?
It is not recorded because it's supposed to be a kind of a free flow of information, and I think that wouldn't happen if it was recorded, because I imagine that the physician would be afraid that would be discoverable in a malpractice case.
So with that understanding, and with the understanding that you received from the presentation materials, I think we need to go back to the department and ask for a little bit of clarification, because it seems that the information is against each other. And I will leave that up to the discretion of this commission. Review of cases. As we've talked about, the review of cases to determine NUPC goes from the investigative committee to the full board. Now, the quorum rules, again, going back to the quorum, illustrate that 13 members total on the board, 7 must be there. 7 of the 13 must be present for this hearing. However, those that were on the IC must not vote. If you are on the investigative commission, you cannot vote in the actual proceedings. So that leaves, if all members were present, 9 voting members. The potential concern that came up last hearing was that an IC of 4 members finds NUPC. The board of 13, less the 4 members, votes to remand the case back. That can happen. The case gets remanded back to the IC to determine whether or not their finding was accurate. Who reviews this case? Is it the same 4 members of the IC who review it? And then when they make a determination, what happens? It goes back to the board. But the board has already heard the case. The board's already heard this case and remanded it back. It was found NUPC, remanded back, and if the case was determined as NUPC again, the same individuals are hearing that case a second time. Or if it was found UPC, now the same individuals are hearing it again. And this sounds like a hypothetical illustration, but as the department illustrated, there have been 13 cases since 2013 that have been referred back, that have been remanded back to the IC for excuse me, for further investigation. Of those 13 cases, 2 were found UPC. Again, outlining some of the questions in your packet, the BMLD is not aware of any cases overturned by judicial proceeding. A couple of other questions regarded the physician forms, the registration forms. At what point must a complaint box yes be checked on the registration forms, and the department provided their answers. There's also sample complaint forms in your packet. A question regarding case priority came up. At which way, how does the determination of cases and threats reach the IC unit from the team triage, the team review? And you can see here, it's unintentional actions take a secondary step against intentional actions, with a few cases provided. And again, emergency actions by the department are the highest level priority, and that is above and beyond what this scope entails. To refresh your memory, you've seen this slide before. This is pending cases of the BMLD. What your questions focused on was the 2-year frame, the 12 outstanding. You asked whether or not, first, why were these cases still outstanding after 2+ years? And the department provided a list of some of their reasons, that several are no longer pending as physicians and are not practicing, cannot be located, some of the challenging administrative tasks therein. However, they did stipulate that all are considered very low priority and do not pose a public health risk to date. The other question that you posed was whether or not the Legislative Assembly could do anything to help with this backlog. And they provided 2 suggestions. The first being adding more seats for the allopathic physicians, and the second was to provide an incentive for doctors to reach out and speak to the board in terms of finding authority. Treatment recommendations were another topic of the questions. The Physicians Health Committee, which is a program operated by RIMS, which stands for Rhode Island Medical Society, I believe that our next presentation will be a little bit more knowledgeable than I am on this regard, so I'll briefly go through it. Most of the facilities frequently used are illustrated in this slide. Again, the questions for referral compensation, the department said there was none, no such compensation provided. Treatment evaluations. How is treatment evaluated, used in further proceedings, and deemed complete on behalf of the physician? I read that because that is the exact question provided by this commission, and the response by the BMLD was the facility sends a report to the BMLD, which, judging by your question, was seeking, I think, a little bit more with how it was used in the proceedings, later proceedings for the doctor. A little bit of clarification could obtain from the department on this. Average cost of treatment, depending on what the actual facilities in use are, could be $5,000 to $10,000, and that, from our understanding, is paid by the physician. Federation of State Medical Boards. Rhode Island is a paying member of this organization. However, there is no specific contract or agreement of any nature, of any kind. They do not facilitate referrals or receive for physician discipline, anything of that nature. The rules and regulations. At the onset of this commission back in October, the rules and regulations pertaining to the BMLD were under review. They have since been revised and have been improved at this time. They will be available to you shortly after this hearing. There are no pending regulatory matters in front of the BMLD at this time. Towards the end of the question packet, at questions 16 and 17, centered upon revision control procedures. The BMLD follows Administrative Procedures Act, as well as state statutes outlined in the aforesaid chapters here. Most current regulations are posted to the Secretary of State's website, and there's a link back in the Health Department to find those most recent regulations. This would conclude my presentation. I just want to mention a couple of housekeeping items. The next BMLD meeting will be on February 24th. The time has not yet been set. However, I'd just like the Commission to keep in mind that the enabling legislation allowed for a reporting date of April 2nd, which Sounds like a far away time from now, but believe it or not, it'll be here before we know it. So we are expecting 2 more commission hearings and then a report coming from then. If you have any questions about the material provided, I'd be happy to answer them if I can, or to take down any questions you may have as we can, again, seek clarifications from the department.
Thank you very much, Jeff.
24th.
Yep, 24th. Yeah, and I'll touch on that before we leave. So I just, a couple of notes that I just jotted down I just want to address real quickly. Revision control, that portion, we received the answers to our questions from the department and the board Friday, I think. Was it Friday?
Yes.
All right. So I haven't had a chance to review that statute. That's a fairly good-sized chunk of legislation. So I don't understand right now what the statute requires, so I can't really speak to it. The Administrative Procedures Act, same thing. It's because it arrived at the time it did. I haven't had a chance to review it, which I am very interested in doing because of, for me, the importance of revision control and a robust and healthy management of the revisions that these processes go through. This is sort of irregular, and I took a note. We have Ms. Coleman and Ms. Harrigan in the audience today, and I know you weren't scheduled, so it would be irregular for me to ask you to come up. But at one point, I saw you shaking your head when we learned that the IC must have a quorum of 3 of the 4 members. So was that incorrect?
It was that he was calling in a hearing, and the hearing, so I was afraid there was confusion between the hearing panel and the IC.
Okay. All right. Thank you.
IC does need a quorum of hearing panel level.
Thank you very much for clarifying that. So, because you weren't mic'd up, I will repeat that the IC requires the quorum of 3, whereas the panel does not.
That would be the team review panel?
No, the hearing panel, which is when it goes to an administrative hearing, it does not need a quorum. That's not
Okay. And then on page 10 or slide 10 of the presentation, where you spoke of the review of the cases, I found that intriguing. When it's referred back and then goes back, so to speak, into the hopper and then comes back to the same panel. So I think what I'd like to see is, and I will get this formalized, but I think I'd like to see a little bit more of a look into that. Right now, I don't have anything specific on the top of my head that I can speak to, but it begs a lot of questions in reviewing it, and I think I personally need a better understanding of that. I don't know. Other members may have questions that are more direct. Those were the notes I took down. So at this point, I will open it to the floor if anyone has questions at all of either the presentation or additional information that we might like to get our hands on from either the BMLD or Department of Health in general. So if you have any questions or document requests, information requests, now is the time. Yes.
I have a question, maybe, excuse me, it may be for Representative Chippendale or Jeff, but what is the process for us to get further clarification from the Department of Health? The question really being, will we have an opportunity to have someone from the Department of Health at a different level from what we've already seen be in front of us so we can ask questions?
I'll take that. We did attempt to have the chief administrator from BMLD, Dr. McDonald, here last week. Oh, I'm sorry. Time flies. Last month we had Ms. Coleman and Ms. Harrigan here in his stead from the department. Whether or not we ask them to come back is up in the air right now. I'm not sure if we will, but the chief administrator himself is not able to come in. Yes.
Curious as to why he wasn't able to come, and will that be something that could change in the future?
I don't think it's going to change. There's a pending lawsuit that he is involved in, and that has necessitated him to sort of take a step back and remain away from just an open hearing. It's the type of a thing where being involved in litigation, you don't want to engage in a public dialogue because it would be discoverable. So it was more of a safety precaution, a legal safety precaution on his part. So it was not because he didn't want to. Thank you. Representative Morgan.
Yeah, thank you, Chairman. I thought we were going to get information about the consent orders, how many of them were entered into before there actually was any kind of formal investigation, and whether people seeking, litigation were using the BMLD to triangulate, kind of force the issue. I thought that we had said we were going to get some information about the number of times that might have come into play.
So if I'm understanding correctly, I think that the information that we had provided on consent orders were consent orders ratified and decreed. In regards to the judicial component of that, there have been, from what the department said, to their knowledge, no overturning of UPC cases. You may have to rephrase.
No, I think it was when doctors are asked as part of their adjudication of the issue to settle things in the judicial system before the final disciplinary action is taken by the BMLD. Did we ask for that? Thought we were going to.
Not to my knowledge, no, I don't believe so. I think that could be a question that we refine and then ask to the BMLD.
Okay. All right, thank you.
And that's specifically what we would like to accomplish is if there were things that either we expected an answer and maybe it just was never asked, or if there's something new that we'd like to ask, this is the forum to get that to the clerk, and Jeff will be able to then pursue getting answers to that information. So with that, I believe Dr. McAtee, you had your hand up.
Yes, thank you. So the Physicians Health Committee, it appears that that they're the ones who determine the treatment for the physician. And when we were discussing the process, it didn't seem like that was part of what the BMLD was sort of determining. It seemed like that they would have consent decrees that they would then determine that the physician needed to get certain treatment or to follow different recommendations. So I'm wondering how many get referred to the committee. Does the committee just make the recommendations of the different facilities, or do they make recommendations based on the physician's need, based on the determination of the consent decree? So I'm just wondering what the connection was. It's a little bit confusing to me.
Sure. Understanding that, I think the consent decrees have outlined in them various measures through which the doctor must take to either obtain their license back or to keep the license, I think. And through that, generally speaking, I think the department would have more information on this than I. Educational requirements are posed in those consent decrees.
Sure, and yeah, the facilities, they're determined by the Rhode Island Medical Society, so they don't determine like the treatment, they determine only the facilities, or who determines the treatment? Is it the...
That may be something we can pose to the medical society when they come up. I think that would be most prudent.
So the other thing that was interesting to me is that they came up with some ideas on how to improve the process, and one of those was to have fee-levying abilities. And I'm just wondering what their recommendations for that might be, what kind of fee levying abilities they would like to have for that, what the recommendations that they would have specifically around that. I'm very curious how that would be helpful for this process.
So you're referring to the fines?
The fines, yes.
Fines for an incentive base? Sure.
And I'm also curious if there's an ongoing process. It seems that some stories that I've heard from other physicians are that the process is never complete for certain people, that they have to keep going back for lie detector tests or various things. That would be very curious to know whether there are people that have ongoing treatment that's not been completed with their consent decree, and for how long that would possibly last, and the costs involved with that.
We'll pose that to the BMLD.
Yes, please.
Okay. Relative to the last question asked, with the consent orders that are given to the physicians or the medical professionals who have come before the board, we were able to find quite a few of them floating around on the internet, where folks had either posted them on their own or their public record. And really, there's such a wide variety of actions that are taken, and sanctions, if you will, that are imposed, whether it's educational courses or treatment centers or what have you. But I too do have a curiosity about that, in the sense that I'm curious, and this may be something, again, that the second portion of this hearing may help us understand better. If there's a pool, so to speak, of regular resources that are used for those courses, and then if there's sort of, typically this term has a negative connotation, but in my usage of it, it shouldn't. Is there a boilerplate almost where a physician who may be facing a complaint that's not unsimilar to something many physicians have faced before, is there a sort of boilerplate that is used? So perhaps that's a question we can pose. And again, it's not a negative connotation. It's just that when you're seeing the same thing over and over again, it's like speeding tickets for police officers. They have a very prescribed method they go through. Is there something similar to that, which would serve for a couple of things? It would certainly offer consistency in the meeting of sanctions, and then it would also allow physicians and others to have sort of a guideline of what to expect and where to expect that they're going to be going after that. So if that's something that we can maybe elaborate on in a request, that would be helpful. For the members of the commission, and we did have two who sent their regrets today, were unable to attend, they will still be able to send questions to the clerk. If anything comes to mind, if anything document request wise comes to mind, they can be forwarded to the clerk. We'll get them over quickly to BMLD and or health, whoever would be most appropriate to answer it, and then that will be part of a future presentation. There are some, as we noted, some things that seem to be either contradictory or just maybe unclear. So we want to get those straightened out, so we have a full flow chart of the process, which will be presented. So with that, I'll throw it out there one more time. If there are any questions or things that folks would like to see. Going once, going twice. Okay. So, Mr. Robert, thank you very much for the presentation. And at this point, I would like to invite Mr. Steve DeToy from the Rhode Island Medical Society on up to. Yes, of course you may. Mr. Ward or Dr. Ward is always welcome.
Whoops. Thank you, Mr. Chairman, members of the commission. I'm going to just have a brief opening remark, and then I'm going to ask our Executive Director of the Medical Society, Newell Ward, to give us some history on the Board of Medical Licensure, since he is the only person I know that was here when the Board of Medical Licensure and Discipline was originally established by the General Assembly. And the one remark that I'd like to make is, and if you on the Finance Committee, like Rep. Morgan, you know, you've heard me say this before, but in my experience, there's no department in the state that has a larger delta between what they're asked to do and what they're funded to do than the Department of Health. And that delta goes down through all levels of the department. So with that, I'd like to introduce my boss, Dr. Newell Ward.
Thank you, Steve, and thank you, Mr. Chairman. My name is Newell Ward. I am the Executive Director of the Rhode Island Medical Society. I've held that position since 1988, and I've worked for the Medical Society since 1984. So, as Steve says, I have lived through some history, including the entire history of the Board of Medical and some of the prehistory of the Board of Medical Licensure and Discipline, which began its work, as you know, 29 years ago in January of 1987. And I want to thank Steve for being here. I've often said that Steve is my right hand and my left. He is our Director of Government Relations and Public Affairs, and I know he's well known to you, and I'm glad he's here to help make sure that I give you, you know, in the short time that we have, as full and accurate picture as possible of our what we know and what we perceive about the board. I appreciate your time and attention today. Steve and I have listened carefully to the presentations that you have heard to date, and we believe we do have a couple of important background and perspectives to offer to you that have not come out in previous testimony. Two quick things maybe before I really begin. First of all, thank you for this commission, for this work. It's been a long time. I think it's been 30 years since anybody looked closely and systematically at the structures and processes by which the medical profession in Rhode Island is regulated. And it's good, of course, to do this once in a while, and I thank you very much for digging into the due process issues. It's very interesting to me, and I don't have all that on the top of my head. I will say there is, of course, always a natural tension between the regulators and the regulated, and in this case, between the board and the medical community. We think this tension is wholesome, it's valuable, it's necessary, and an important part of what I want to tell you today is that we, while we certainly have had our concerns from time to time over the years, from the perspective of the Medical Society, the board, throughout its 29-year history, has functioned well overall. And the tension that I speak of has remained wholesome and within proper bounds. And that's a credit to a lot of people. And I will mention a couple of those people in what I want to present to you. So I'm not here to attack the board, and I'm not here to defend it either. But overall, I will say that we find that it has functioned well for almost 3 decades. The second quick thing I want to say as a preface is simply to tip my hat to my representative, Mr. Winfield, whose constituent I am. My family has lived on Stillwater Road for better part of 30 years, and my wife and I have visited your facility more than a few times. Thank you for your service to your constituents in Smithfield, and thank you for working with the Medical Society and with Steve all these years. I want to really say just 3 broad things, 3 areas about the Board of Licensure and Discipline. I want to talk about its unique structure. I don't think that has come out in previous testimony. And I'll talk more briefly about the quality of the leadership of the board and the way it functions. And thirdly, I want to talk just a little bit about the nature of its funding. So first, structure. The structure of the Board of Medical Licensure and Discipline is unique in the nation. And especially it's unique in one very striking and important way. I use the word unique in its true sense, not just that it's unusual, but that there is really only one. Counting the District of Columbia, there are 50 other medical boards in the United States. All of those other 50 medical boards are dominated by physicians in the sense that physicians make up the majority, meaning more than half of the members of those other boards. Rhode Island is different. When the General Assembly designed and created the Board of Medical Licensure and Discipline in 1986, and by the way, the Medical Society was there. We were well represented on that study commission that was chaired by Senator Michael Fort. Probably know him. He was a senator then, later became a family court judge, now retired. The Medical Society was represented throughout that long process by Dr. Herbert Rockatansky. So in other words, we helped design and create today's Board of Medical Licensure and Discipline. So as I started to say, back in 1986, the General Assembly was concerned about two things, balance and accountability. The intent of the General Assembly back then was clearly to have balance between physician interests and the public interest. And as a result, the board is 50-50, with the governor appointing 6 physicians and 6 lay people to the board. True, the law calls for the director of health, who by Rhode Island law, I think, must be a physician, to chair the board. And so the director becomes the 13th member of the board, but the director merely presides, if she's there at all, and the director is, after all, a full-time public health official and a state employee, not a practicing physician. So again, the intent of the legislature in 1986, and I remember these discussions, was to create a 50-50 balance of physicians and laypersons, and that's what we have in Rhode Island. That was a radical idea, to have parity on the board. And I would ask you to think about every other board that regulates every other licensed profession. Think of the dentists, the nurses, the podiatrists, the physician assistants, the accountants, the attorneys, the financial advisors, the morticians in this state and in every other state. All of them, all of these regulatory boards, as far as I know, and it's easy to verify, all of them are dominated numerically by the members of the profession they regulate. All of them, in other words, are essentially peer review boards. They are made up of licensed professionals who evaluate and pass judgment on their peers. And who better to do that, of course? It stands to reason that only an attorney or an accountant has the standing, the expertise to evaluate and pass judgment on the work and behavior of another attorney or another accountant. Now, to make sure the public interest is being served, to make sure that professionals are not protecting each other, we typically include a few laypersons on these boards, but they are never in the majority, and with exactly one exception, at least among state medical boards, the lay people are never in parity with the professionals either. The Rhode Island Medical Board is that one exception. There's a second way in which the Rhode Island Board is unique in the nation. It is unique in that it requires that one of those 6 non-physician members shall be, and I quote from the law, an attorney with experience as plaintiff's counsel in the presentation and prosecution of medical malpractice matters. No other state does that, as far as Steve and I know. And there again, you see the General Assembly's concern about providing an effective public interest, patient's interest counterbalance to the physician perspective on the board. As an instructive sidelight, maybe, let me mention that the unique structure of the Rhode Island Medical Board has attracted some national interest in the last 12 months. Because of a U.S. Supreme Court ruling that was handed down a little less than a year ago in February of 2015 involving the North Carolina Board of Dentistry and the Federal Trade Commission. The FTC came down on the North Carolina Dental Board for sending cease and desist letters to non-dentists in North Carolina who were providing teeth whitening services. Now, under North Carolina law, I understand it's quite clear that teeth whitening is part of the practice of dentistry. Accordingly, the North Carolina Dental Board accused these non-dentists of practicing dentistry without a license. However, the FTC considered this to be restraint of trade on the part of the Dental Board. And the FTC pointed out that the North Carolina Dental Board was dominated by dentists. And it argued that these dentists were abusing their authority to stifle competition, contrary to the public interest. The FTC, for the interest of the attorneys in the room anyway, the FTC argued further that the simple fact that the North Carolina Dental Board was an agent of the North Carolina state government was not enough to qualify it for the so-called state action exemption to antitrust. So the battle was on, and it went all the way to the U.S. Supreme Court. In its decision early last year, last February, the Supreme Court of the United States agreed with the FTC. And the ramifications of that ruling are potentially enormous. As you can imagine, the Supreme Court decision has prompted much soul-searching all across the nation because, as I have pointed out, it's very much the rule, almost universally the rule, that professional regulatory boards are peer review boards, and as such, they strongly tend to be dominated by the members of the profession they regulate. Now, the U.S. Supreme Court has called that very common structure into question and thereby raised the possibility that professionals who serve on dental boards, medical boards, all kinds of state regulatory boards all over the country may be subject to antitrust liability for simply doing their jobs as board members. And at the very least, they probably ought to be indemnified. A lot of states are wrestling with these questions right now. And in all this discussion, the ensuing discussion within the medical community and the legal community about antitrust and state regulatory boards, it has been noticed and remarked upon that Rhode Island appears to be the only state that does not have to consider restructuring its medical board because we are, by design, 50-50. Physicians and lay people. So much for the topic of balance. I said the General Assembly, when it structured the board back in 1986, was concerned about balance and accountability. I've talked about balance at some length now. I can be more brief about the accountability piece. The predecessor for the Board of Licensure and Discipline before 1987 was a body called the Board of Medical Review. The Board of Medical Review was an entity unto itself. It was quite independent. It didn't report to anybody. It was not a part of any state department. It was clearly not accountable to anyone. And so the General Assembly in 1986 designed the current board very differently. First of all, it placed it within and under the Department of Health. And second, it made a cabinet-level person, namely the Director of Health, the chair of the board. And so our current Board of Medical Licensure and Discipline is accountable to the Director of Health, and through the Director, it's accountable to the Governor and to the General Assembly. So now I've talked about structure, balance, accountability. I will be much more brief in my two other points about the quality of the board's leadership and its function. And finally, I'll have very little to say about the funding. When the current board began its work in January of 1987 within the Health Department, the director of the Health Department at that time was Dr. H. Denman Scott, who's still in the community. Dr. Scott did us all a huge favor in the fall of 1986 when he somehow managed to recruit Dr. Milton W. Homolsky to serve as the first chief administrative officer of the new board. Dr. Homolsky had just retired after serving for many years as the beloved and revered chief of medicine at Rhode Island Hospital. Dr. Homolsky, who passed away 2 years ago, was the most magnificent human being I personally have ever had the privilege of knowing. And many others would say the same thing. I know probably some of you knew him too. He was a giant. And he was the perfect leader to put his stamp on the new board and on the office of Chief Administrative Officer of the board. I think he served in that position for about a dozen years or more and served very ably. Dr. Homolsky is chief among the people who set the tone and the culture and the precedents for the way the board still works today on a day-to-day basis. And that is a good thing. Another person who deserves credit for the constructive, not easy, but definitely constructive relationship that has always prevailed between the board and the medical society is Dr. Herbert Rockatansky. Dr. Rockatansky has, for more than 35 years, chaired the physician health program of the Rhode Island Medical Society. And I could talk all day about our physician health program, and I welcome your interest. We're very proud of it. It's very important, but I promise not to talk all day about it. And in a nutshell, I think you already do understand what it is. The Medical Society established the physician health program to address physician well-being in the broadest sense, physician stress, physician suicides, to address drinking and drugging among physicians classically, and all kinds of other behavioral issues, sexual boundary violations, disruptive behavior on the part of physicians, substance abuse, senescence, physical impairments, just all kinds of very difficult, very sensitive issues that have strong ramifications for patient safety and quality patient care. And ultimately, that's what it's all about. And we work not only with physicians, by the way, we also work with the entire dental community, the podiatric medical community, the physician assistant community. And in short, we provide a huge and invaluable service to the entire healthcare system in Rhode Island. We save reputations, careers, marriages, and lives, and ultimately, of course, we are protecting patients, patient safety, and quality patient care. It is, in short, an example of professionalism at work. And just by the way, for the past 25 years, we have also conducted a parallel program with the medical students at Brown University. I need to mention the physician health program to you because it's through this vital and sensitive and very confidential activity that the Medical Society and the board interact with each other on a daily or almost a daily basis. Our physician health program is very busy. Over the course of the past 35 years, we've worked with almost 600 physicians, dentists, podiatrists, and PAs, and at any given time, including right now, we have an active caseload of about 50 or 60 individuals. Many, maybe most, of the referrals to our program come from the board in the form of, it's an element of those consent decrees that you were talking about, that thou shalt get in touch with the physician health program of the Rhode Island Medical Society and do what they think you need to do. And I'll be happy to talk more about that. Our other referrals come from hospitals, a lot of them, from residency programs, from group practices. We do get some self-referrals, but the vast majority of the referrals that come to us are involuntary. So we need the board to back us up, and the board needs us to do what they cannot do, which is to evaluate, determine a course of action, prescribe a course of treatment, and then carefully monitor recovery over a period of at least 5 years. The physicians sign a contract with us. So maybe this is a good point for me to, I think, begin to answer, maybe, or try to answer some of what you were asking about how this process works. I think it is fair, and again, I must say, I'm not, as executive director, involved with the work of the physician health program. It's very confidential. We have a full-time clinical social worker who is the director of the program, and she in turn is supported by 2 part-time people, and she is supervised and directed by a committee of volunteers, which is made up of physicians, podiatrists, dentists, and physician assistants. The board, as I understand it, you've seen these consent decrees, they are not specific. They say, go to the Rhode Island Medical Society and do what they tell you you need to do. And we then, and we do not perform evaluations. We do not provide treatment. We have a stable of professionals and institutions that we refer people to, and sometimes we give them choices, sometimes we don't. And I think you saw a list that Mr. Robert provided to you, and I'm not necessarily up to date on which institutions we use, but I know we send people all over the country depending on what their issues are. We may send them to Lawrence, Kansas. We may send them to a place outside of Atlanta, Georgia. Williamsburg, Virginia is another one. There's one in New York somewhere. We direct people according to their needs to evaluators and to facilities and to programs, all tailored to the individual physician's needs, or podiatrist or dentist. And they sign an elaborate contract with us. And these contracts used to be 3-year contracts. They're now 5-year contracts. And they have many elements to them that, random urines are very common, a relationship with a psychiatrist, a relationship with a psychologist, participation in one of our therapy groups. We have 3 of them going in the state. Alcoholics Anonymous and the other programs may be required, and so on. And we monitor these participations. We get the urine reports and so on. And the physicians who are the clients, shall we say, of the physician health program, they pay their own way with all of these things. They have to, pay the facilities in Williamsburg, Virginia, or whatever, or hopefully they have good health insurance that will cover a lot of that. I think you have been told, maybe in a previous presentation, that somehow the clients of our physician health program also pay us, and that's not true at all. We would not demand, and we would not accept payment from clients of the program. We would never turn anyone away who needed the services that we provide. And we would never turn away anybody who did not pay or would not pay, because they don't have to pay us.
Doctor, if I could interrupt, we are closely approaching when the legislature may be called up for session, so I'm going to rudely cut you a little bit short, and I do apologize for that in advance, because the board or the commission does have questions we want to ask. So at some point, legislators may get out, may have to duck out and head upstairs. I will remain here. And so that we can get some questions. So I do want to allow as much time for that as possible. And you did touch on, actually, and it was a very nice synopsis of the PHC for us, because that's precisely what our interest is. And with that, I think by opening up to some questions, we can kind of move the dialogue in towards some of the specificity that the members want to go. So if you may indulge, that's how I'd like to proceed.
Absolutely.
Thank you very much, Doctor. I will take questions from the floor. Dr. McAteer.
What is the what is the relationship back and forth between the boards and the Physicians Health Committee? So somebody signs a 5-year contract, and then what is the relationship that goes back and forth between the two
excellent. I think
organizations?
I can speak to that. It's a very important question, and it's one that I wanted to get into. It is, of course, it is, again, it's an arm's length relationship, but it's a very important relationship to us and a very important relationship to the board. And I would say, again, it's a very wholesome and healthy relationship, mutually respectful and productive, but it is also a relationship that we work at quite systematically. We meet twice a year. In the fall, the board comes to us and meets with us on our turf, and in the spring, we go to the Department of Health and we meet with them on their turf, and we talk about how things are going and what the rough spots have been here and there, and that way we avoid a lot of misunderstandings. Not all of them, but a lot of them, and you know, the fact that we work so systematically at this relationship, I think, demonstrates how both parties value it very much. And those connections, maybe, I think those daily connections are mainly between our full-time clinical social worker and Dr. McDonald.
So, for example, if a physician has a consent decree that they need to go talk to the committee, and you sign a 5-year contract, can you kind of walk us through that process of then what happens and how then you communicate back to the board and what information is communicated back?
Yeah, I left that out. You're right. So there are many elements to the contract that the client signs with us, as I said, and we monitor all those elements. So there's a flow of information coming to our clinical social worker and to her clerical support, and we try, and we also do upgrade our systems and make it tighter using technology and so on over the years. We've made progress in that regard. And so we can say with a lot of confidence that if someone is in compliance with all the elements of their contract, they're clean and they're doing well. And once a month, we will send a message to the board indicating that so-and-so, and simply that, I think it's a one-sentence communication, so-and-so is in compliance with all the terms of their contract. If there's a slip, then we report that immediately.
Which, Dr. McTerry, if there is a slip, that 5 years starts basically over the time frame,
right.
Or whatever.
Good point. Thanks.
Can you explain how it changed from 3 years to 5 years and what it might look for an individual physician if they were, what the contract might seem like or what the requirements might be to be a part of that contract, and then what the requirements might be that they would need to meet those for those 5 years and why it changed from 3 years to 5 years? Can you give us kind of like walk through a general example?
Yeah, I think as a psychiatrist, you would know better than I, but my sense is, and I was not part of those discussions, I just, heard about it, but I gathered that on the basis of maybe the scientific literature and maybe on the basis of the experience of our committee, we decided that 3 years wasn't enough and that it needed to be longer. I don't think I can give you a better answer than that, but I can certainly bring you someone who can.
Excuse me, Doctor, I apologize. Representative Morgan is about to head up to the floor, but she does have a question, so I'm going to allow her to squeak in, and we'll go right back to you.
Yeah, I'm really sorry, Doctor. You jump in right after me and finish your line of thought. Are the physicians that enter the consent decree, are they given due process? I mean, are they able to prove that maybe they don't need it after all, the treatment, or are they allowed to say where they would rather? I mean, you said you send them to Lawrenceville, you send them to Georgia. What if they would like to be treated more locally? Do they get that ability?
As far as I know, I can say they may or they may not. I do know of situations where we have, referred clients to a particular forensic psychiatrist, and I think, well, there are some that we work with regularly and have great confidence in, and they understand our program, and we like our reports, and a physician may say, well, geez, I've got this other psychiatrist that I have a relationship with. Couldn't I have him or her do it? And we won't always agree with that. And I don't know all of the reasons, but it's based on the experience of our clinical social worker and our committee. So I guess, yes and no. And certainly if somebody wants to find treatment closer to home, I'm sure we try to accommodate them.
They're paying for this, correct?
Yes,
so shouldn't they have
very expensive.
It's very expensive, and if it's out of state, it's even more expensive. So shouldn't they have some input into who they want as their treatment physician? As a patient myself, I get to choose my doctors.
Yes.
And why do we take that right away from physicians?
I'm not the best one to answer that. I can only say that we have 35 years of experience doing this, and we have facilities and individuals we've identified that we find are good to work with, and there's a lot at stake. Our credibility with the board.
Theirs as well. They're not going to shortstop their ability to continue practicing, right? But they still would seem to me should have the right to due process and also to kind of choose on who they want to work with.
Yeah, certainly, and due process is the province of the board. Ours is more, I guess I would say, a medical approach that we arrive at a judgment of what this individual needs to get well, and to be fit to practice medicine again. And certainly there's some flexibility, but I don't know how to characterize that flexibility.
And Rep, remember that this physician or dentist or podiatrist, whoever, has signed a consent decree with the board or with their own licensing board that they agree to the treatment or agree to be compliant with whatever the provisions of that consent decree are. So if they're referred to the Medical Society's Physicians Health Committee and they decide they don't want to go where, they have that discussion. That's not a due process issue. This is a peer review issue where the credibility of the physician who's being referred and the physicians and other practitioners on our health committee have to have a lot of confidence in, because we are, in essence, protecting the public health at this point.
And I honestly understand that very much. But I also wonder just how heavy-handed it is. Just because you're a physician doesn't mean that you give up your right to due process or your right to choose who you are comfortable as a patient working with.
And I think what Dr. Ward was getting to is that if the people who are going to put their name on the fact that you agree that you completed this contract have to have confidence that the person providing the treatment meets the standards of our group. Just because, so there's, and it does happen on occasion, but I'm not sure it always happens, and I'm not sure that it ever comes up all that often. But again, we don't staff that. That's a separate, it's funded in a separate way. It's not part of our budget. We house them, and but they run that committee totally separate from us.
And you, I guess you can understand if your license to practice is in jeopardy, you're going to agree to almost anything, and it might not be in your best interest. That's all. Thank you.
You also know from many afflictions that sometimes your judgment may be impaired at that point, and you may do almost anything, including seeking substandard care in order to get back your license. So there's that balance between that goes on, and again, it happens. I don't know how often someone who's been referred to our committee asks for that option, but it's certainly considered. There's no blanket policy that it's our way or no way.
Oh, okay, thank you.
And Dr. McAteer.
So you had mentioned that the funding comes through a different section. Can you elaborate on what the funding for the committee is? Who pays for the social worker? Who pays for the part-time people?
Yeah, it's a coalition of institutions mostly and individuals who have a stake in patient safety and quality patient care. So that includes all of the health insurers in Rhode Island. It includes all of the medical professional liability insurers. It includes the hospital as all of the hospitals and the hospital systems as institutions, their administration. It also includes the hospital medical staff associations of every hospital in the state. It includes a number of professional associations besides those hospital staff associations. A number of specialty societies support the program, including, of course, the Podiatric Medical Society, also the Rhode Island Psychiatric Society, the Academy, the Rhode Island Academy of Physician Assistants, of course, the Rhode Island Society of Osteopathic Physicians and Surgeons, as well as the Rhode Island Medical Society, and several of the larger medical practices also pitch in. You know, Coastal Medical does, Providence Anesthesia, University Surgical Associates, and several other of the larger practices. And then there's some individuals who
Some of the alumni contribute to the organization as well.
So it's a community effort. You know, it's something that the populace of Rhode Island, in a very broad sense, benefits from and is protected by, and so it's a community effort to help make it financially viable for us to do this. And that's all for personnel. The members of the committee, it's a large committee, a multi-specialty committee of about 25 that includes not only physicians, but the dentists, the PAs, the psychiatrists, of course there are psychiatrists, the podiatrists. They are all volunteers. They're all 100% volunteers, but our clinical social worker, we can't pay her enough for what she does. She works very hard, puts in very long hours, but she is a full-time employee of the medical society, and she has 2 part-time, as I mentioned, clerical people. That's where the money goes for the most part.
Is there funding from other outside organizations like the AMA or the Federation of State Medical Boards or the ABMS? Are there outside funding from those organizations?
The AMA?
The AMA, the Federation of State Medical Boards, or any of the ABMS licensure?
Doesn't contribute
Curious, yeah.
Funding to our program, no.
Okay. So does every physician who is referred to the committee, do they all have to sign a 5-year contract?
No, it depends on the evaluation. Again, we farm out the evaluation to someone, and depending on the report that we get back, we may say, well, this person doesn't have a treatable condition, or it's not appropriate, for physicians.
So they might be referred out for a forensic psychiatric evaluation, for example, or what kind of evaluations and how many do they get sent out for? What kind of testing is done for those initial evaluations to determine what the treatment is needed at that time?
Yeah, it is neurological, psychological, psychiatric. There may be sensory issues testing. It may be. And I think, again, the evaluation is tailored to the issues that brought this individual to our attention, or to the attention of the hospital, or to the attention of the board, or to the attention of his colleagues in the medical practice.
So I'm just curious, how many, I'm just trying to give a sense for the members of the committee to kind of understand what the process might be. So a physician gets referred to the committee, then they get sent for 1 to 5 evaluations from different people, and who then determines whether that is sufficient, and where they get sent for more evaluations, and at what point do they then sign on to for the 5-year commitment to, and then the 5-year commitment, what does that include for that physician, just so that we can get a general understanding of how this process works for a physician if they're in that position?
You're asking me about the evaluation process and the.
How many?
I have to notice I wear 2 hearing aids, and I'm having a little trouble understanding you. So, just acoustically.
Sure, I'm sorry. So the question that I have is how, if you could walk us through the process, just so that we can understand from the committee what happens to that physician. So they get a consent decree, or they say that you need to go get evaluated, they get sent to your committee, and if they go to how many evaluations before that they could possibly be cleared, or they get sent back if some of those come back perfectly fine, and at what point do they then sign on for a 5-year contract? And then what does that 5-year contract look like to the physician, just so that we can understand the process for what might happen to a physician if they get sent in this direction?
Excuse me, Mr. Chairman. With the majority of the board not here, shall we even be continuing this hearing?
There is no necessity for a quorum, but we are coming up against a hard break relative to the legislature. They are already upstairs doing business, so we're going to.
We live very nearby, Mr. Chairman. We're happy to come back at the convenience of the committee.
Absolutely, and I think what we may do is probably, as we have with the others, is put together a list of questions based on the members' input. Steve, I can certainly hand that to you tomorrow or any other day, and maybe go that route, because I don't want to undercut the quality and the relevance of the questions nor the answers. Both are equally important in this, and in an effort to meet the fact that there is a commission or a committee being set up for this room immediately preceding the House proceedings, which will be wrapping up shortly. We're running into a logistics problem.
And the fans have begun to gather.
The fans are starting to gather. So I beg the indulgence of all the commission members who I saw studiously writing notes down for questions. We can get those to Jeff, who in turn will get them over to REMS. And at that point, we'll have a reviewable content, and you guys are always welcome, of course, to come back. We may squeeze in an extra meeting just for that. I apologize to the members. The timing is very difficult with the House being in session. With that, I want to just put out there that our next meeting, as pointed out earlier, is on the 24th of February, and I'm going to be attempting to have a 2 o'clock start time and see how that works with the members. The scheduled topic was going to be some public testimony that at this point has not been set in stone, but those in the public looking forward to it, please keep an eye out for the agenda. With that said, I do want to thank, I will start with Mr. Lees, Ms. Galligan, Dr. McIntyre, Representative Morgan, Representative Azenauer, Representative Winfield, and Jeffrey Robert, the clerk. And on behalf of us all, thank you for appearing today. Thank you for making yourselves available in the future. And I will regrettably have to conclude this meeting a little bit earlier than I would have liked to, but we will pick up where we left off and take it from there. So with that, this meeting is adjourned, and I will see you all in at least on the 24th of February. If not, we'll get a schedule reassessed for you. Thank you very much, and have a good evening.
Thank you.